many of you are aware, in the United Kingdom there was the ATOM study, so access to transplantation and transplantation outcome measures. And basically it had different prongs looking at adults having access to transplantation, their survival, and as you've heard, we're usually quite good with our patient survival, both on dialysis and after transplantation, their quality of life, some health economics, and organ allocation. And we are proposing to do a study in children which looks at some of these different aspects. So I'm just going to go through some of the timeline that's happened as a way of introduction and then show you some of the data that we collected prospectively. So we had a viewpoint of doing this 3 years ago, and as you know, it takes some time to get approval from our national bodies, but in 2017 we actually went back and said to the units, can you tell us some of the data that's happened to your patients? And we nationally agreed that this was going to be kind of one of the national studies that was going to take forward. So I'm going to talk to you a little bit about what happens in the UK, because we know with data that there's variation in access to transplantation, and part of it we've shown previously with our decline rates, and Chris talked about this very briefly, but just to show you that we looked at what happened to discarded kidneys, so in other words, offers that had happened to different units that had been declined, and we found that 82% of kidneys that were offered to children were indeed transplanted, and about 10% of those actually went into children where their overall outcomes were reasonable, but maybe not quite as good as we'd had hoped, and maybe as we discussed, part of that is because actually some children have longer and more pressing issues clinically. So what we did is we basically looked at all of the data that was coming in from the UK Renal Registry, but we actually asked for supplemental information on not just the children who were on dialysis and not just the children who were renal transplant recipients, but with stage 5 chronic kidney disease, CKDT, so those patients who've got very poor renal allograft function where their estimated glomerular filtration rate is less than 15 mils per minute per 1.73 meters squared. In addition, we also added in patients with native chronic kidney disease, and this is a group who we don't have data in the United Kingdom, but as the years go by, we're going to be collecting more data through UK Renal Registry. So we managed to get data from 12 of our 13 paediatric nephrology centres in the UK. So we had 308 patients in total of a mean weight and height of 28 kilos and 117. As you can see, the majority of these patients were actually being dialyzed, so 58%. There was about a third who were preemptively transplanted, and as you can see, there was an eighth, about 12% of them had stage 5 CKD. And I've put down there, if you're desperate to see your unit and what your numbers were in the UK, then you can see it in this chart. And then we asked specifically, based on your census date of the 31st of December, what are your plans for transplantation for this patient? And what we found is that although about 41% of them had an identified living donor, and there was more that were going through donor workup, there were quite a few patients where they were being listed for a transplant, but there were quite a few where it was just in a preliminary discussion. So we touched a little bit yesterday, but this is actually data in the UK saying why are these patients not getting preemptively transplanted? And about a third were because of these crash landers or children presenting an end-stage kidney disease. About a quarter were because of a lack of a suitable living donor. And of course you could question, well, should you not be activating on call for the deceased donor waiting list? Obviously, there are some patients who are going to be less than 15 months who they said they were too young for transplantation. But I think Sam's comment is right, that there are patients we know from our decline data around the United Kingdom who've got weight restrictions on deceased donors. So we know that those patients are not being offered living donor transplantation in some centres because of the worry of using large kidneys going into small recipients. When we looked at what the actual barriers for transplantation, one of the things which obviously is unsurprising is about a third were because of disease factors. But what was really interesting, is probably underreported, is about a fifth were due to psychosocial factors. And I think as we did touch on yesterday, the importance of the psychosocial aspect is really very important. So we're really hopefully going to get some accurate benchmarking, trying to share best practice and see what happens in different centres to try and promote not only preemptive transplantation but early transplantation. And as part of the British Association for Paediatric Nephrology, we're talking about having KQIP, which is quality improvement initiatives, and also about trying to see whether we can improve preemptive transplantation rates. So we're proposing to do an atomic project, which is looking at the access to transplantation and the outcome measures in children. We've now in the situation where we've got a project board together and a project team, and we've had some grant submissions, but we will going to be needing people in the audience and around the country, but also within Europe. We've just been awarded a grant from the European Society for Paediatric Nephrology, so we're going to look at what factors may actually cause variation within different countries in Europe. So part of it is to consider having a questionnaire on what are the barriers within your unit, what are the barriers do you feel within your teams, but also at a patient level, and also a consideration is maybe should we independently be reviewing patients before they go on call for a deceased donor transplant or within individual units. We do about 140 to 165 renal transplants in the UK in children, so it would not be unsurmountable to have a central board where we look at what's happening to these patients on a potentially annual basis. So I'd like to thank all the 12 paediatric nephrology teams who are involved. Some of the data collection was done by consultants, some by nurses, some by trainees, but specifically the two trainees in London, so Ram and Matko, and also Jisoo, who's going to be taking this project forward. We just heard we got money from Kidney Care and from the British Renal Society to do this in a more prospective manner in the United Kingdom. Thank you.